Welcome to the committee, Representative Krisha. Representative Krisha, I will move House File 3650 be laid over. We have the bill before us. There's no amendments. Representative Krisha, to your bill.
Thank you, Mr. Chair, and I'll be brief. This is a bill and a program that many of you are aware of, and I'm back this year because of the success and also the allocation that we had last year. Anytime we move through the early stages of a program, it takes a while to get things up and running. So everything's starting to come up to speed, and we have some successes, and so we're back here asking for a continuation. I won't spend a lot of time with it because the two folks that have been at the front and center of this, Dr. Devine and Dr. Bell, know it much better and frankly have been the champions and the advocates. So I'd like to turn it over to my testifiers.
Welcome to the committee, testifiers. Please introduce yourself in whatever order you would like and proceed with your testimony.
Thank you, Mr. Chair. My name is Kirk Devine. I'm a physician at the Family Medical Center in St. Gabriel's in Little Falls. I just like a couple disclaimers. I think that often when we're talking about opioids, I think that we're looking at everything. I'm going to talk about doom and gloom, and I'm not going to today. I think we're going to talk about hope and what we're trying to do to fix this problem. The other disclaimer is we are not addiction physicians. Both Dr. Bell and I are family doctors in Little Falls who've been working on this program for 3 years now. We are working on two programs. One is with MDH, which is this program. We're also doing something with DHS through doing rural teaching for opioids prescribing and for medical assisted treatment. And this one is, today we're here about the other. We do have handouts. I don't know if we...
Paige has them.
Oh, wonderful.
They're being passed out.
Perfect. And we were asked to do this program by MDH because of the success we had in our program. We have been doing this now for about 3 years, where we started in our clinic basically walking ourselves through every single patient that we had on controlled substances using a team of a social worker, 2 physicians, a nurse, and a pharmacist. And over those 3 years, we have stopped almost 500 people's medications that they really didn't need. We have cut out 500,000 pills that were controlled substances in our clinic during this time. And so we've shown that you can do this if you really take the time. And I think it's important for people to understand when you look at the heroin addiction that 4 out of 5 people start with the pills that they're getting from our clinics. And so we look at the front end of this. I think that often people come and they want to talk about medical assisted treatment as a primary thing, but we're trying to keep people from falling down that path by not getting them the medications that they frankly sometimes don't need. And so that's really the most important part. The second thing that we are teaching and that we are bringing to these 8 communities that we'll be dealing with is actually medical assisted treatment. As you know, all the addiction doctors are in the Twin Cities, Duluth, and Rochester. There are not addiction specialists in the metro or outside of the metros. And part of our progress is really to put those people out in the rural communities, and we've done that already, and we're going to continue to do that so there's access for the people living in those small towns and those rural towns. And I'll let Dr. Bell talk a little bit about what we're doing in these towns and exactly what finances and such they've gotten as a part of this program.
Welcome to the committee, Dr. Bell. Please introduce yourself and proceed.
I'm Heather Bell. I'm also a family physician in Little Falls, Minnesota. So finally, we just got our 8 communities selected. 4 of these communities are all getting $100,000. The other 4 communities are all getting $75,000. With that money, those communities will be building their team similar to what we have in our community. They need a physician, a nurse in the least. Some of them are using that money to get a social worker and a dedicated physician, so physician time to really work on their program. Basically, in order to get the grant, so these 8 communities all needed to have a community task force, so members of each community, not just the clinic people, but community members have to have a task force. And then they needed their team in the clinic to really sit down and be able to go through patient charts one by one. They need a nurse that's dedicated strictly to monitoring patient charts and helping support the physicians in their clinic. Getting care plans done, monitoring urines, monitoring patient prescriptions, and then they needed to get physicians waivered and buprenorphine, so their Suboxone waiver to do the MAT. Really, another component is really the patient-centered medical home, so whole person care. We really want to make sure that in our rural communities, patients aren't just fired from clinics if they have drug issues, but rather they're treated with a comprehensive care plan. Obviously, these communities will need to do data. They'll need to monitor their pills, their care plans, how many buprenorphine patients they have, how many overdoses they are not having as many of. And with this, we're able to mentor these communities. The goal is to really be able to get on the ground, explain to these communities, mentor, be there for these communities, whether it's us going to their communities or using our telemedicine echo program that we also do to really show them that this is possible in their communities. This is a very overwhelming problem that all these communities have. We want to say, hey, we wrote this book, which we have a manual we're giving to them. We've already worked through all the workflow. We already know how these processes work to be able to really just get there and help them just get started to have the same success. And again, focus on getting the pills cut out of their communities. Our goal right now with our 8 communities is to cut 1 million opioids out of the state, which we totally think is possible. We've had other communities across our state just starting, and they've already cut hundreds of thousands of pills. A million pills, roughly about $7 a pill. That's $7 million saved in just the pills, and that's not counting the emergency room visits, all the phone calls for early refills, and all the other services that most of these patients are on state-funded insurance. I mean, that's a lot of money that we're hoping to save the state in just the pills. And then, of course, be able to treat the patients in rural Minnesota who have already gotten to the addiction problem.
Thank you, Dr. Bell. We appreciate your testimony and for your work, and Dr. Devine for your work in pioneering efforts in your area. Is there any other testifiers that you have, Representative Krisha? Is there anyone from the audience who would like to testify on this bill? Seeing none, we'll close the test. Oh, is there somebody? All right. Please make your way down to the testifiers table. Introduce yourself for the record and proceed with your testimony. If you could keep your testimony to 2 minutes or less, we would greatly appreciate it. Welcome to the committee.
Hi, my name is Andrea Hunt. I'm a nurse at the University of Minnesota Masonic Children's Hospital. I work on the postpartum floor, and I'm actually here as part of the Student Nurses Day on the Hill. And I want to speak really briefly about opioids. Pardon me if you've heard these statistics, but in Minnesota, opioid deaths have gone up 430% since 2000. And as you stated, 80% of Americans addicted to heroin start out using prescription pain medications. On the postpartum unit, opioids are a far-reaching problem. If women don't get into treatment, there's the healthy infants that come to my unit that are watched for drug withdrawal, and if it's bad enough, they go to the NICU. But many of these infants whose moms come in on the opioids, they're put into a 72-hour hold. A lot of them will go into the foster care system. And from 2015 to 2016, there was more than a 10% increase in overall children placed in foster care for the first time. And according to MDH reports, that's a directly related to the opioid crisis. So the need for comprehensive interventions in clinics is really important for these mothers to not come in. And starting in 2016, for the first time, drug abuse was the primary common complaint of kids being removed from homes over alleged parental abuse.
All right. Thank you for your testimony, Ms. Hunt. We do appreciate it, and thanks to all of the students from the University of Minnesota who are here today. Member questions, Representative Liebling.
Thank you, Mr. Chair. Not really a question. I just really wanted to, commend the testifiers for your great work. And I remember when you first came just to report on what you were doing, and it was so impressive. And like you say, to hear actually something that's working. It's been a long time concern of mine that the PMP, the Prescription Monitoring Program, is, I've been kind of a skeptic, I would say, of that program because it gives physicians a tool or prescribers a tool to know when somebody might be in trouble, but then it just doesn't, there's nothing to follow up. And what you folks are doing is following up. And so when Representative Krisha asked me to sign on to the bill last year, I guess, I was very happy to do that because I really think this is a great approach, and I'm really glad that you're modeling this for other communities, and really appreciate your efforts and wish you a lot of continued success. I hope we can fund this. Thank you.
Great, thank you.
Representative Considine.
Thank you, Mr. Chair. The 8 communities, is that a secret, or can you tell us who they are?
They have not been released yet. They are chosen, but we were asked not to yet.
Oh, okay, thank you.
It's a secret. All right, further questions? All right, seeing no further questions, thanks again for all the work that you're doing for sticking your neck out and trying something that hasn't been done before. It's been very successful. We appreciate that, and appreciate you practicing in Minnesota, and appreciate you taking time away from your patients to be here today. Representative Krisha, final word.
Thank you, Mr. Chair, and thank you, members. Yes, what a fantastic program. And one of the things that I just want to highlight, or two things I want to highlight that the testifier, the nurse came up, Ms. Hunt said was, this is directly tied to child protection, which is something that's near and dear to me as well. We know this ties back, and we need to have second and third generation solutions if we're going to change this. And the second thing that I just want to highlight that this group has demonstrated to me is this is not, there is no easy fix. There's no magic program. It's a grind. And it's a every day, day in, day out, try to take just pills off the street. I mean, there is no magic wand. It's a grind, and they've demonstrated that. And so I thank you for your support, and I hope we can continue with that.
Thank you, Representative Krisha. And with that, House File 3650 is laid over. Thank you.